great pleasure to be here. Yeah, we really value education as orthopaedic oncologists because regrettably, we do see examples where sarcoma maybe hasn't been treated appropriately. And it's largely because it's such a rare cancer. It's a complicated cancer as well, with over 70 different histological subtypes. We span this benign malignant spectrum, which I'll try and explain to you. But it only makes up 1% of all cancers. And so it's not probably at the front of our brain. Maybe we're on a busy on-call night and we see someone who may or may not have a pathological fracture. Are we thinking that it could be a chondrosarcoma? We don't want to take that to theatre and nail. We want to work it up. And my colleague, Tom Koska, will be talking very much about the workup of these cases tomorrow. I'm going to just concentrate on this range of bone tumours from the benign to malignant spectrum. They have a number of different treatment algorithms. Most involve surgery, and another have various degrees of effectiveness with chemotherapy and radiotherapy. I think the great thing about sarcoma is that it occurs around the body, and so we have mainly hip and knee surgeons who do sarcoma, but we often need to bring in other specialists from other areas. And it was great when we appointed Tom Koska as one of our colleagues at Oxford, because he'd done a shoulder fellowship, so we could get him really concentrating on upper limb sarcomas. And I work quite regularly with other surgeons in the bowel, the chest, etc., in trying to deal with these difficult cases. Just for some facts, we see approximately 100 bone tumours a year in Oxford and about 200 to 300 soft tissue sarcomas. It's a normal, that rate, the numbers you see is 5 to 1 soft tissues to bone. And these are the numbers that you tend to see a year in England and Wales. This is just a soft tissue sarcoma at the back of the knee. Yeah, sorry about that. So yeah, so we're here now just talking about the fact that that's a soft tissue sarcoma, and the normal sort of relationship between bone and soft tissue is 5 to 1. And there's about 1,500 soft tissue sarcomas in England and Wales per year, and about 350 bone tumours. This is a soft tissue sarcoma here, and this is quite a classic site for a bone tumour. And I normally sort of ask the question what this is, and most people come up with the exam, no, this is a parosteal osteosarcoma. Quite a unique site for that type of tumour, and is known by the examiners, so you might see that. The other thing about sort of sarcomas, I said they occur all around the body, but most of them tend to occur in the lower limb. 10% around the pelvic girdle, 40%, 6% in the lower limb. We do see intra-abdominal, intrathoracic, and the odd head and neck, and about 13% are in the upper limb as well. So yeah, this is where we have to get that site-specific expertise sometimes to help us deal with these cases. And really, this is what I just want to sort of highlight why education is so important, is to try and think always about the potential for not just sarcoma, but maybe even metastatic disease. When you're seeing sort of unusual presentations of fractures. And if it doesn't quite seem right, just take your time, and hopefully your radar will get especially attuned as you get more experience to knowing when things is not right. Take your time. You don't need to rush them to theatre, despite maybe the pressure on getting patients on pathways. Try and make a diagnosis if you've got anything unusual. So this is a case that really drove this home to me right at the start of my consultant career. In the first year of practice, I got referred this 32-year-old male, fit and active, who'd been kite surfing in Turkey. He'd fractured his femur and had it nailed, and then was flown back. 3 months later, the fracture was not healing. And I think you can see that there is a lytic deposit. And it really wasn't really noticed even at this stage 3 months later, because the patient went for exchange nailing, and at exchange nailing, they found, I'm just trying to make sure I can get, that's probably a tick on there. And at exchange nailing, they found renal cell carcinoma, and they also found staph epidermidis, unfortunately. So we've got this situation where that was a nailing of a metastasis. He also had they found the primary in one of the kidneys. What do you do? And yeah, ideally we should have, before this nailing was put in, that should have been, and in fact should have been noted. You can see there's definitely lysis at the bone end, and that patient needs to be properly worked up. Now, metastases are important. We do see them quite regularly. They're much more common than actually sarcoma. And these are just some ribbons that people wear to represent the various cancers on fundraising days throughout the year. These are the major metastatic deposits in the bone. So these are the major osteophiles. And I just want to mention metastatic disease first because it is so common. And it's increasingly becoming more common as the treatments the oncologists give to patients get better. There's breast, prostate, lung, renal, thyroid, GA. They're the ones that spread to bone. There's actually a difference between a number of these. There's the cancers that really at the moment don't have a lot of oncological treatments. And their survival can be measured, as you see here, in months, the lung and the colorectal. And then there's the cancers that actually the survival now is in years: breast, prostate, kidney, and thyroid. Many years, in fact. And I've just seen a patient who had kidney cancer 15 years ago who's still alive. And if you look at here about the chance of these fractures healing, you can see that on the whole, if you have a fracture from these metastases, they're not likely to heal. Prostate might, but on the whole, the rest of them might not. So that's important when you are faced with patients with pathological fractures or pathological lesions. So you don't want to miss it because it can cause problems. And the other thing is mistaking a primary bone tumor for a secondary. Just assuming an elderly patient has got a metastasis, if they haven't got any previous history of a primary, is wrong. Any solitary lesion in bone is a primary malignant bone tumor until proven otherwise. The other problems that we see in metastases is you underestimate patient survival. As I said, you don't realize that some patients, particularly with kidney cancer, can live 10, 15 years now. And so you've got to do the right operation for them. And the other thing is to overestimate the fact that you just nail and you think that radiotherapy is going to kill that cancer and cause bone healing. It won't. Fractures do not heal. And I just want to emphasize some of the problems we see. This was a beautifully plated distal femoral fracture undertaken in Marseille, I think. They had a lot of time filling the screw holes here, and I'm sure the trauma surgeons amongst you would be a little bit critical of the stiffness of this construct. But anyway, at this stage, despite it being a low energy injury sustained playing tennis, there was no concern about this fracture. And then unfortunately, 3 months later, the plate broke because the fracture wasn't healing. And only at this stage did they diagnose in the fracture that there was a renal cell metastasis. A nailing was then undertaken, but really we're not addressing the issue that renal cell has got a long survival, that it will very rarely heal this fracture, and yet we're asking metal to splint this and aim for healing despite maybe some radiotherapy. And so you can imagine what happened, like sometimes it happens in my operating theatre with some of the instruments that I use. They get metal fatigue and they fracture. And the fact that a lot of these cancers are very radio insensitive. They really don't respond to radiation, whereas breast, prostate partially does. What we find is that this happened, the nail and the screws failed. What do you do to this patient who's got solitary renal cancer here, and you potentially could live many years? Well, you can't keep doing intralesional surgery. In this case, you have to go for an en-bloc resection and bring in a tumor-type prosthesis. And this patient actually did very well and was walking out of hospital within 3 days after having what should have been the definitive operation in the first place. So what do you do with this patient with renal cancer and Staph aureus? This is this kite surfer. He only had a kidney cancer. There was no other disease. This is solitary disease, our metastatic disease. you've got to be quite aggressive. And this is the patient who now is 15 years after presenting that I still see in my clinic. We were very radical. We did a total femoral resection, keeping a big soft tissue cuff around the fracture site to make sure we got all the kidney cancer out. We gave him a spacer for 6 weeks, gave him some antibiotics, and then that's a spacer. We make it out of a long nail, an old nail that we cover in antibiotic impregnated cement. So there's lots of antibiotic elution into the soft tissues as well as IV therapy. And you just jam it into the tibia, you give them a cricket bat splint, and they can mobilize. It's actually a reasonably comfortable construct. And then I gave him a total femoral replacement.
Yeah.
And this is him walking.
I think turn around. Okay.
And this guy lives on the south coast. He windsurfs, he goes skiing. And what was fantastic, about 8 years ago, so 8 years after he presented, he brought in his baby, and he's had 2 more children since. So you mustn't write these metastatic patients off. They've got these new biological therapies which are doing tremendously well in these patients. And I'm hoping that even lung and colorectal cancers will start to see benefits of these treatments. And you'll see them living years rather than months. And so we've got to get the right reconstruction of the patients. So that really sort of summarizes where I think metastatic is so important, because it is a bone tumor. And I think that it is largely poorly served. But you, for the exam, may well get this case. An 80-year-old male, he's fallen out of bed. He's got a classic intertrochanteric neck of femur, or maybe even a subtrochanteric neck of femur fracture. You've got the scenario that you want to take him to theatre, or the anaesthetist wants to get him to theatre quickly because the targets are important and they've got to get them done early. What do? You've got to be a little bit concerned, haven't you, just looking at the matrix here, that there's something going on. You're going to be concerned that maybe the patient, from your history, has had some pain previously in the run-up to this fall. And so this patient is to be stopped. It's not to go to theatre. You're going to work it up. You're going to work it up with what Tom's going to describe tomorrow. You're going to get an MRI scan. You're going to maybe get a chest CT abdomen. You're going to try and see what this is. This could be a metastatic deposit, or as a solitary lesion, with this patient having no known history of cancer, could be a primary malignant bone tumor. And so this is really where in the exam, they're trying to make sure that you as the consultant on call are safe, and that you're going to be really just cognizant that there could be other pathologies going on, and not letting this go to theatre like you could do. And the answer is, this was a clear cell chondrosarcoma. Luckily, it was biopsied. We were then able to take the patient after the biopsy and do this type of operation, rather than a neck of femur osteomore that would contaminate the area even further, and probably might even necessitate us doing a through hip amputation. So that's what we want you to be sort of thinking about, when metastatic disease is a much more common presentation than sarcoma. So this is just in summary of my metastatic talk, is don't do this, guys. Don't refer to pathologists. Refer to your local sarcoma or oncology unit for advice, or send the patients there if you've got any concerns. So I want you to get an idea on sarcomas, which is quite a big subject, that you can actually break it down quite nicely into various different categories. I've already sort of told you that there's bone and soft tissue sarcomas, ratio of 5 to 1, but also sarcomas are named because they come from tissue of mesenchymal origin. They come from mesoderm tissue. And that's cartilage, bone, muscle, fat, smooth muscle. And so all these have slightly different types of tumours. As you know, the Latin moniker is given to these: the chondro, the osteo, the rhabdo, lipo, and leiomyo. I'm sure you can know those. And there's this benign malignant spectrum. And I also want you to understand there's a bit of a a structure you can do, and then your further reading will allow you to sort of build up some of the more detail about them. So there's benign and malignant. The benign tumours tend to be classified into 3 types of aggressiveness. There's latent, like a non-ossifying fibroma. There's an active, a bit like maybe an enchondroma, maybe aggressive, like a giant cell tumour. Break them down into these major tissue types: bone, cartilage, fibrous. Then unfortunately, because we're not all nice and simple in sarcoma, I've got a 4th group, miscellaneous. And that group, I'm largely going to talk about the cysts. Malignant, your aggressiveness is low, intermediate, high grade. And again, you can break them down into these 4 major categories: bone, cartilage, and fibrous tissue, and then a miscellaneous. In that miscellaneous, I tend to put Ewing's or round cell tumours because they don't fit really anywhere else. So apart from the miscellaneous category, which is a little bit messy, everything else I'm going to talk to you fits nicely into these categories. So you can look at these any x-rays and think, is it a bone, cartilage, or a fibrous tumour? I've quickly talked about metastasis. That's probably a subject all on its own. We could have another seminar at some point on that. And occasionally you do get hematological malignancies as well. Again, we don't have the time really on that. So I'm just going to concentrate on this spectrum of benign to malignant in these categories: bone, cartilage, fibrous, and miscellaneous. So you can see that in bone, when the matrix is mainly bone forming, the benigns are these tumours, moving up to the malignant, the osteosarcoma. And I'll talk about the periosteal ones, the surface ones, as well as the more classic central osteosarcoma. In cartilage, these are the benign tumours you should know a little bit about, moving over to the chondrosarcoma. And there's a few different types of chondrosarcoma I'll touch on as well. Fibrous, again, these are the benign fibrous tumours, moving on to the slightly more aggressive malignant version, fibrosarcoma, adamantinoma, MFH, which actually has changed its name now to the pleomorphic spindle cell sarcoma, and I'll touch on that later. And then the cysts, you do see a number of these cysts. So I think I do need to talk about them: the giant cell tumour, the ABC, unicameral, and then the miscellaneous and malignancy is just about the Ewing's, which we'll touch on at the end. So I really think if you get that sort of structure, thinking about whether that's bone, cartilage, or whatever, and to get an idea whether it's benign or malignant, that will help you try and work out what the tumour potentially could be. So the examiners love their x-rays on their computer. You'll sit at the desk, the examiner will turn the computer around to you, and you'll have an x-ray on the screen. They won't want you to touch it. They want you to get your pen out to sort of just touch around what the important features. So this is what the vivas do. They get you talking and describing x-rays. First thing is to talk about, just if you want to have some thinking time. So you can just start off just saying what the x-ray shows, or what the x-ray is that's obviously a knee AP x-ray, and this is a CT scan. And then you can talk a little bit about where there's maybe a lesion. Think about the epiphysis. Think about the metaphysis or the diaphysis. The reason I say that is that the nice thing about sarcomas, even though it's very complex with 70 different types of subtypes, what you find is that there's only a very few that like the epiphysis, a few more like the metaphysis, and then just a few like the diaphysis, like adamantinoma and Ewing's. So this is a really good diagram to commit to memory, because it just allows you to see where the lesion is, and it can hopefully trigger whether it's one of these types of tumours. It's an ability to help. Also the age, you can see whether there's still growth plates, so you can get an idea whether it's maybe a paediatric problem. And paediatrics would tend to be thinking about Ewing's and osteosarcoma. Where it's the growth plates are fully formed, it's going to be of adult age, and then they may be sort of some of the other tumours. So you can do this sort of description of the X-ray while you're actually thinking about what it could be. And then, do you think it's a bone matrix, a cartilage matrix, or is it maybe a fibrous matrix? What's the lesion doing to the bone? Is it eroding it, or is it just sitting there nicely corticated? And is there a soft tissue mass? Try and get in the habit of describing X-rays in this sort of sequence. So going back to this X-ray, this is an epiphyseal tumour. So already after describing it, you'll know there aren't many epiphyseal tumours. So you'll hopefully come up with eventually maybe a chondroblastoma. But as sarcoma surgeons, it's never always quite so nice. So you've always got to just be careful and say, even though I think it's maybe a chondroblastoma, we'll always be getting a tissue diagnosis. And that's important because very occasionally you can get, unfortunately, a clear cell chondrosarcoma in the epiphysis that you never want to be caught out on. So there's always a little bit of muddying rather than the rules. This is an apophysis. This is a greater trochanter. This is an epiphyseal equivalent. So this is, again, a chondroblastoma. You can see there's a little bit of spickling as though it's a cartilage matrix. It's a relatively walled off tumour. So you don't think that is that aggressive. So that a chondroblastoma, which is a benign aggressive tumour, fits in quite nicely. So really think about that diagram. Think about what part of the bone the tumours are in, and it can often give you a good help to come up with a meaningful differential diagnosis. And you can see on the MRI scan there was a cartilage matrix. So this X-ray, you can describe this a little bit further. It's a metaphyseal epiphyseal lesion. It's quite permeative. There's cortical destruction. Yeah, you don't know where the tumour finishes, really, do you? It's all like spreading through quite a lot of the bone. So this has definitely got an aggressive air to it. And this actually was a lymphoma, which was destroying the proximal femur. So those sort of few phrases that you can use to describe it are useful for you to come up with a differential. And I would say that you can often use differential tumours such as, in your differential diagnosis, tumours such as fibrous dysplasia. And you can always often say this could be infection as well. Infection's a big tumour mimic, and that can often be brought into your diagnosis. So you can see that it's quite disruptive there, and that was a lymphoma. So, and here now you can see, what's this matrix? You can see it's probably bone forming. And you can see there's probably some bone out in the soft tissues here. There's some little bit of Codman's triangle there with the periosteums raised up. It's a mixed lytic picture here. So and it's also eccentric in the metaphysis. So that's hopefully triggering you to come up that this could well be an osteosarcoma. And that's what it was. So yeah, unfortunately I can't sort of get you talking, but normally in my talks I get the delegates to describe these because it just gets people sort of coming up with the vocabulary to describe these X-rays. And then you've got here, that's quite nice. You can see that we can definitely know where the tumour is. There's not there's a nice thin geographic zone around it. And that could either be fibrous dysplasia or a unicameral bone cyst. Maybe infection could be brought in the differential if you as well. This is an expansile lesion, distal radius, and it's a metaphyseal tumour going into the epiphysis. And we'll see that later in the talk as a giant cell tumour. And these are the sun ray spicules you see in aggressive. And this is actually more in the diaphysis than the epiphysis, than the metaphysis. And this actually in a pediatric patient is a Ewing sarcoma. So let's just carry on straight on to just go through some of the routine tumours, which are the benign bone tumours. This is a patient who had pain at night, seemed to be relieved by aspirin. You can see something here in the neck, and you can see this on the CT scan. So this is a classic history for an osteoid osteoma, which is an osteoblastic tumour. There's a few sort of details here, which you can get from all the textbooks. A lot of these tumours like the younger patient. Most of them tend to have a male predisposition. And as you know, the classic history for osteoarthritis is night pain, relieved by aspirin and non-steroidals. It can occur in the back and cause a scoliosis. It can occur near the knee joint, the hip joint, and sometimes cause a joint effusion as well. The treatment is with radiofrequency ablation or potentially curettage. A CT scan often nicely shows that there's a lesion in the bone, and it's never really bigger than a centimetre. And you occasionally en bloc excise them, but we largely just put a probe in under CT control. That probe heats up to about 90 degrees for about 10 minutes. That completely heats up the tumour, and that often causes resolution and bone infilling. So that's the osteoblastoma, really the start of this spectrum of bone tumours from benign to malignant. This is the bigger brother of the osteoblastoma. This is, again, a lesion in here, it's in the metastasis. It's a little bit bigger. It's bigger than a centimetre. And actually, it can be a little bit more aggressive than osteoblastoma. And this is called an osteoblastoma. Again, you can see a little less common than osteoblastoma. Same sort of demographics. Again, still likes going into the spine, and seen in the posterior elements in about 30% of cases. Again, very similar investigations, MRI and thin section CT scan is often hot on bone scan. And it can be mixed up with ABCs, giant cell tumours, even chondroblastomas sometimes. And you would tend to want to treat these with en bloc excisions or curettage and bone graft. And you'll see whenever we do curettage these lesions, these benign lesions, we always tend to, unfortunately, claim about 10 to 20% recurrence rate. So you can always say that in the exam. That seems to be uniform amongst any tumour that we curettage. Just be always a bit careful, though. Even though it looks benign, you can get an osteosarcoma called a Telangetic Osteosarcoma, which I'll show you later, which unfortunately is a very lytic lesion. And so you've always got to make sure that you never really diagnose an osteoblastoma until you've got a tissue diagnosis, because you don't want to miss a telangetic osteosarcoma. Then we're moving on to the cartilage benign tumours. We've got something called an osteochondroma, which is that a disorder of the growth plate, where rather than the growth plate expanding horizontally, cartilage gets chewed out laterally. And so that's how you tend to get osteochondromas from childhood. Again, very similar demographics that we've seen before. Two types really of osteochondromas. They can be the sessile flat type or the exostosis stalk-like, often asymptomatic, but can cause some mechanical symptoms on adjacent tendons and ligaments, can be painful if they're not. You really only treat these though if they're symptomatic. However, if after maturity, after you've got skeletal maturity, you're getting increasing growth in one of these osteochondromas, that is worrying, and that does increase the risk of it becoming a malignant chondrosarcoma. Also, if there's a cartilage cap bigger than 2 centimetres, that would worry us for it changing to a chondrosarcoma, and they're the indications for treatment. So we see them around the knee, shoulder, and hip. Often the bone scan is relatively cool. But yeah, this is a sessile osteochondroma between the tibia and the fibula. You can see how long-standing it's been there, with that long-standing erosion of the adjacent fibula. So if you just saw that X-ray, you could be a little bit worried there's maybe a bone tumour and another type of bone tumour there. But that long-standing change on the fibula should reassure you. That's actually what, on cross-sectional imaging, you saw on the osteochondroma, and that cartilage cap is bigger than 2 centimetres. So that would worry us that there may be within this cartilage cap, there is some malignant transformation into a low-grade chondrosarcoma. So you're going to get pictures like this, and the examiner's going to say, what is this? And you know that you've got osteochondromas here, but you've got multiple, maybe causing sort of growth abnormalities. And so you've got a condition of multiple exostosis, multiple osteochondromas, and it's called HME, Hereditary Multiple Exostosis, or previously known as diaphyseal achalasia. It's an autosomal dominant condition, variable degrees of penetrance, number of clinical manifestations, very occasionally malignancy. Just because you have so many osteochondromas, they recommend they have a very small chance of malignancy in each one, so you do have to be a bit careful. And the books vary on what they say is a risk of malignancy. I've seen some textbooks talk about 1% risk of malignancy. Well, I've always known it about 0.2% in every osteochondroma. So if you've got maybe 100 or so, that might be significant. But we're much more keen on these patients just reporting increased growth after skeletal maturity or increased symptoms like pain, and then we'll treat them. We don't routinely follow these patients up. So HME is an important one. Then you've got cartilage tumours within the bone, and these are called Enchondromers. And these are very common, and they often do sometimes cause some diagnostic difficulty when they're seen in otherwise patients who are asymptomatic because of adjacent joint problems. So we get a lot of cases just sent up from our knee surgeons who've just done knee x-rays, and they see these cartilage tumours above them. Benign cartilage tumour is quite common, again, relatively affected in young people, mainly in the long bones, so we do see them in the hands. And just to sort of show, these are how these cartilage tumours are formed. These are just being chewed out from the growth plate, become exostoses or osteochondromas, or they remain as remnants of the osteogenesis of the of the bone formation when kids mature. And they come inside the bone. And the question is, are they chondrosarcomas or are they enchondromas that you can watch? This is with them in the hands. In the hands, they're often lytic, actually, and you don't often see the cartilage stippling. But tumours in the hand are very often benign. They're very, very rarely malignant. So you can be relatively reassured about hand tumours. So this is how you decide whether you've got a chondrosarcoma or an enchondroma. And it can be a little bit tricky. And this is where it's useful to get your advice of your local oncologist to sort of, to give you that idea. So you can see here, this is a little bit more extensive, this stippling in the distal femur here. And there's also intermittent lytic areas. And there's also some endosteal scalloping here, and the patient would probably have some pain at rest as well. And this is quite clearly a change, and this is going to become a chondrosarcoma. As compared to, let's just go back to here, there's no endosteal scalloping. This is just looking like a cartilage tumour, and this is still an enchondroma. So how do you sort of tell the difference? Then just my little table to try and give you an idea. You tend to sort of, just have to weigh up all the evidence. You get a clinical history, you look at the cross-sectional imaging, you also maybe look at the bone scan, and you do have to sort of make a judgment call on how far the evidence forms into potentially being a low-grade chondrosarcoma and enchondroma. Low-grade chondrosarcomas you'd want to treat with a curettage. Enchondromas, you don't treat, but you probably want to watch them and get another MRI scan in 6 months just to make sure there's been no change. If there has been a change, they become low-grade chondrosarcomas and you need to treat with a curettage. Radiologists or your local tumour centre can often help here. This is a condition of multiple enchondromatosis. And again, a nice question that you get asked in the MCQs. It's called Ollier's disease. It's non-hereditary, frequently affects one side of the body, often causes growth disturbance. And the key thing is that this has got a 25% risk of malignancy. So this is a much more sinister condition, and you do need to follow these patients up. So when they've got multiple enchondromas, that's significant and should be referred to the oncology unit. This is a patient who'd had multiple enchondromatosis. He had some changes now in his proximal humerus. We saw that there's significant cartilage here, so this had changed into a chondrosarcoma, And you can see there's cartilage tumor almost all the way down the humerus, very close to the elbow joint. So the only way that we can get a full clearance here was to give him a total femoral replacement. And he's been followed up for some cartilage tumors that he's got in his wrist and hand as well, that you can probably see a little bit on his bone scan here. So we're watching him closely. He is part of regular surveillance. There's another type of form of multiple enchondromatosis, which also has hemangiomas in the soft tissues. And again, it's nicely favored by examiners. That's called Maffucci syndrome. And here you've got 100% risk of malignancy in these patients. It's very rare, no genetic background, but yeah, you often have to be quite prophylactic in treating these patients because the risk of malignancy is very high. Then coming on to another X-ray that often gives you almost like a pathognomonic clue as to what this tumor is. This is called a shark bite out of the proximal tibia. And if you see this, this is a classic site for another type of cartilage tumor called a Chondromixoid Fibroma, which again is a slightly more aggressive cartilage tumor, but still benign, similar demographics that we've seen previously. And it's like this shark or rat bite out of the proximal tibia. So anything in here, it's often classically this. And that could look like a Telangetic Osteosarcoma. So this is where you have to have a differential. It could be a Chondromixoid Fibroma, but you would also talk about fibrous dysplasia and infection if you saw an X-ray like this. So this is where you've got to describe the X-ray, come up with some differential diagnosis, but try and rank them in the order of likelihood. You don't want to go straight in with maybe fibrous dysplasia here. You'd want to probably have Chondromixoid Fibroma as your number one. Treatment is often curettage, and again, the similar sort of recurrence rates with curettage. Then you've got the Chondroblastoma, which we talked about right at the start of the talk about the epiphyseal tumours. And we talked about them being one of the few tumours in this, and the only thing that sometimes can recreate it is a clear cell chondrosarcoma, just to be careful. Again, these benign tumours are often treated with curettage and bone graft. So again, apophysis is an epiphyseal equivalent. And so you could have a tumour here in the left scrotum, again, very similar, would be like to be a chondroblastoma. And the talus bone is also an epiphyseal equivalent. And so if you've got a lesion of the talus, that's often a chondroblastoma as well. Then we're coming on to the fibrous type tumours now. We've done bone, cartilage, fibrous. This is called fibrous dysplasia. And you can see that actually can actually be used in quite a lot of your differential diagnosis when you have lytic tumours. And this is meant to have this glass, this ground glass matrix appearance. But on some of the quality X-rays, it's sometimes difficult to sometimes appreciate that. So fibrous dysplasia is very common, not hereditary, often seen in the femur, tibia, can also be seen in the upper limb, and can be polyostotic when it affects just one side of the body. We only treat it if it's symptomatic. Largely, it can be left alone. If you just curette fibrous dysplasia, fibrous tissue will come back. So the only way you can really turn fibrous tissue into bone is to do proper bone grafting with structural allograft or structural autograft. And so if you've got a lesion in the neck of the femur, you may want to bring a fibrillar graft into it to stop it becoming that shepherd crook deformity that you see. So here we put a fibrillar graft up that was vascularized, and that does luckily then turn fully to bone. If you just curetted this and put some morselized bone graft in, that bone graft would be taken away and you get fibrous dysplasia back within a year. So yeah, you can only really use structural allograft in fibrous dysplasia. Again, a nice one for the MCQ is McCune-Albright syndrome, which is polyostotic fibrous dysplasia with cafe au lait spots, precocious puberty, accelerated body growth, and premature fusion of growth plates. So so that's an important sort of thing that sometimes you just need to know some of the stigmata and some of the signs of this. And then we're now coming on from bone, cartilage, fibrous to the cysts, the miscellaneous group. And again, it's this idea that, yeah, you can see that could be fibrous dysplasia potentially, so you might want to bring that differential. It could be infection, but it's a lytic lesion at the end of the bone. It's more metaphysis epiphysis. So the other option is it could be a giant cell tumour or an aneurysmal bone cyst. You get an MRI scan and you nicely see fluid levels, and that gives you a lot of reassurance this is now an aneurysmal bone cyst, whereas a giant cell tumour would be solid. So an annual bone cyst is, again, relatively rare. Young patient, presents with pain, quite an eccentric lesion, and can be expansile. We sometimes see ABCs primarily, or we see ABCs around another sarcoma. So when you look at the MRI scan, you've got to look and make sure there isn't a solid tumour being hidden beneath the aneurysmal bone cyst, because that's the bit that then will need to be biopsied. So it can be an ABC on its own, or it can be secondary to another tumour. If it's on its own, you would just, again, treat ABCs with curettage and bone grafts. Just to really, again, reiterate that you've always got to be thinking, is this a malignancy? And the telangetic osteosarcoma, i.e. the osteosarcoma that doesn't produce bone, is often a mimic of aneurysmal bone cyst. And you don't want to treat an annual bone cyst without a biopsy, just in case it's this, as this can be obviously a very different treatment. So you've got to be always mindful of that benign malignant spectrum, I'm afraid. This is a unicameral bone cyst, and the classic thing about this on X-ray is you get the falling leaf sign, which is a flake of bone that's within the cystic milieu of this cyst. It sort of works away from the growth plate as the bone enlarges. In the upper limb, you can often leave this alone. Occasionally they fracture, they often heal up, and within a few years they stabilize. In the lower limb, unicameral bone cysts often do need immediate stabilization because you don't want them to fracture. Occasionally they've been treated with steroid, but my recommendation if you do have upper limb unicameral bone cysts is master the inactivity. Don't touch them. Occasionally stabilize the lower limb ones. This is being talked about doing injections of steroid, but we don't bother when we see them in Oxford. So occasionally you might need to stabilize the lower limb one. And then the giant cell tumour, which actually is probably a different beast. You've got to be a bit more aggressive with this probably. It does have a slightly higher chance of coming back to bite you with recurrences. The classic thing of a giant cell tumour is that it's a metaphyseal tumour that goes into the epiphysis. So it's never going to be mistaken really for a chondroblastoma, which is often purely epiphyseal. So we do see it in expendable bones. You can do an en bloc resection, but largely you treat with curettage. And I just want to sort of show you how you curette these lesions, because the curettage is very important. You can just window it, but on this case, I'm just going to sort of show you. We take the tumour out with a knife. We do a full curettage, taking anything that we can see out and send it off for histology. This is a curetting spoon. We often get the assistant to have a go as well. Then I inject the cavity with methylene blue. And then we come in with a burr and we take all that methylene blue from in the cavity to make sure we burred every single area of the cavity, hopefully doing a good curettage and removing any tumour cells. And then we want to use a adjuvant just to try and kill any tumour cells still. And we use a mixture of phenol or hydrogen peroxide. And finally, we often put cement into the cavity, which heats up and kills tumour cells as well. And that is probably the best way of doing a curettage, but still has a 10 to 20% chance of recurrence. And if it recurs, you might need to then think of a non-block resection. That's the histology slides with a giant cell tumour. Luckily, I don't think you see too many tumour slides in the exam, but that's quite a classic one of a giant cell tumour. This is the expendable bone, the fibula, and the giant cell tumour likes to go to the proximal fibula. Here you would actually just probably do an en bloc resection, being very careful of the nerve as it wraps around the neck here. So that's a bit of a trawl through the benign. Now we're finishing on with the malignant tumours. these are the three major malignant tumours: the osteosarcoma, the bone, the Ewing sarcoma, the miscellaneous, and the chondrosarcoma, the cartilage. And the fibrosarcoma, I'll probably just miss out because these are the three commonest ones, and these are their incidences in the population. Key thing is osteosarcoma and Ewing's are young people's diseases, whereas the chondrosarcoma affects the middle-aged and elderly. There's a little peak of osteosarcoma in the elderly, where that's due to Paget's. So Ewing sarcoma loves the pelvis. Chondrosarcomas love the pelvis. Osteosarcomas love the knee. That's what you take home from the incidence of their location on when they present. They tend to, Ewing's likes the diaphysis, osteosarcoma, chondrosarcomas, they like the metaphysis. So osteosarcoma is a bone-forming tumour. Most are called central. Occasionally 10% are surface. So the intramedullary or classic osteosarcoma is a high-grade lesion, where some of the surface osteosarcomas are a bit more low-grade. They still need good surgery, but they don't need to have chemotherapy. When you have a classic osteosarcoma, majority of them are a 2B presentation, which means they have burst out of the bone, but they haven't got chest metastasis. You'll know more about the classifications and staging of sarcoma tomorrow. The key thing to think about when you're dealing with osteosarcoma or Ewing's is it's a systemic disease with just an orthopaedic manifestation at the tumour site. So neoadjuvant chemotherapy is the key treatment. Neoadjuvant means the first thing the patient gets is chemotherapy. They then have about 3 cycles of quite toxic chemotherapy. Then they get restaged, and then they have the surgery. And after surgery, they have more post-operative chemotherapy, up to about 6 to 10 cycles, really depending on what the kill rate of the tumour is done by assessing the tumour resection that is taken out. How we do surgery, and Tom will talk about this tomorrow, we often do wide margins on malignant tumours, balancing up preservation of limb with risk of local recurrence, with often some quite complex reconstructions. So central osteosarcomas do sometimes, you get the out phosphatase raised. They like the distal femur and proximal tibia, and primarily it's a bone producing tumour, which can be primitive because it's very disordered. So you often have a mixed lytic bone picture. Can you see that x-ray? You don't know where that tumour ends or where it finishes. So the bone is being destroyed here, and you've got some lytic areas and some bone forming areas. And that's what you should describe in the it's going from the metaphysis into the epiphysis. And this is the MRI scan. This needs a tumor prosthesis in the reconstruction. And the thing about this is you need to reconstruct the extensor mechanism. And how we do proximal tibial resurrections is we always use a gastrocnemius flap. That gastrocnemius flap covers the tumor prosthesis and reduces the infection risk, but also it can help stabilize the extensor mechanism reconstruction. So after about 3 months of keeping the knee still and stiff, they can then start flexing with no extensor lag.
And bend it.
And that's the type of thing you try and do by bringing a gastrocnemius to protect your proximal tibias. And that's what you hope is a good result. I've mentioned this wee beastie a few times, the telangetic osteosarcoma. It's a bit of a nuisance because it doesn't form bone, it's lytic. And you have to be mindful of this when you see other tumours like giant cell tumours and ABCs, and even sometimes fibrous dysplasia. So just remember this, it's not a bone-forming tumour, it's osteolytic blood-filled sponge, I'm afraid. Luckily, not a common osteosarcoma, but you can see how you could maybe describe this as a benign tumour, like fibrous dysplasia or a big unicameral bone cyst, couldn't you? But actually, that's why it needed a biopsy, and a biopsy would have shown a very blood-filled lesion with tumour cells within it, and that needed treatment like any osteosarcoma with neoadjuvant chemotherapy, surgical resection, and post-operative chemotherapy. Then you have surface osteosarcomas, the periosteal, and that pathognomonic X-ray I showed earlier, the parosteal. Both are surface, tend to be lower grade tumours, so they might not need chemotherapy, but still often need wide local excisions in their surgery. So just make your own table up of the differences between the periosteal and the parosteal, because there are some differences about where they come from. But really, I've not really ever seen a periosteal in any other place apart from the distal femur. So if you get a distal femur, a posterior tumour coming around, looking like bone forming, it's probably going to be a parosteal, and that tends to be low grade, but you still do a distal femoral resection to get a wide resection. So that's a periosteal. I don't think I've seen one anywhere else. I've seen periosteals elsewhere, but periosteals, that's the periosteal one. Bone forming, surface, on the surface of the tumour coming from the periosteum. And that actually was a bit high grade, so that actually was given chemotherapy. The classic teaching on this is that your chemotherapy is a big difference in your survival. And we're now getting up to about 70% 5-year survival with chemotherapy, when we didn't really appreciate it was a systemic disease, we were only getting about 20%. We're very active with anyone with pulmonary disease. We resect them, and we've got about 8 or 9 patients discussed on our tumour board every week, all being referred to the cardiac surgeons for metastectomies. We are very aggressive, and that really does help with patients with advanced disease. But the adjuvant treatment is important. I don't think you need to know a lot about chemotherapy apart from that it's neoadjuvant, it's quite toxic, it affects your fertility, it affects your hair, but it's a key thing to get that 5-year survival up. If you just operate, they'll have only a 20% 5-year survival. So I'll just move on and just show maybe sort of what chemotherapy can do. This was a Ewing's that had chemotherapy. It shrunk down, but the tumour cells could still be in this tissue around the fibula. So we wouldn't just do a fibrillectomy here. We would still go and take all the muscle around where the tumour was before. Because even though the chemotherapy has been effective, we don't think chemotherapy kills 100% of the tumour cells. It's a good result when we get up to about 90%. So you can see from this graph, over the years, we've had increasing survival with our osteosarcomas and Ewing's, largely because we're treating them with chemotherapy, allowing us to do tumour prosthesis and limb salvage, whereas in the old days, we were doing lots of amputations. So I think we are looking more and more at the molecular problems that are occurring in our sarcomas. We're really understanding the molecular disorders that occurs, and these are where the new biological therapies are being targeted. The trouble about a number of our sarcomas is that some of the genetic abnormalities are quite extensive. Osteosarcoma has multiple genetic abnormalities, and so it's not at the moment very sensitive to biological treatments. But this is where the future of treating sarcoma is being undertaken. So I'm just going to move on a little bit to just finishing on with chondrosarcoma. Chondrosarcoma is malignant cartilaginous differentiation. It's that cartilage, that calcified matrix. You've got various different grades of chondrosarcoma from 1, 2, and 3, low grade, intermediate grade, high grade. And even within a tumour, you can have different types of grade. All of them can only really be treated with surgery. And unfortunately, as you get more aggressive, the chance of you actually dying from the disease becomes higher. So a low grade has got a 90% 5-year survival, a high grade 29%, but D-differentiated, which is a very aggressive type of cartilage tumour, has got less than 10% chance. Just to highlight that a primary chondrosarcoma arises in normal bone, but secondary chondrosarcomas arise from those benign tumours that I've talked about earlier, such as an enchondroma or an osteochondroma. And I'll just sort of show that cartilage stippling here. This is a pelvic tumour, and you can see that popcorn type appearances. This isn't a bone-forming tumour. This has got calcification in it, little rings and arcs, and this is cartilage tumour. This was enormous cartilage tumour arising from the ileal blade in a 41-year-old male. Here we had to do a very joint-preserving osteotomy, resection through the SI joint, and that allowed us to get this out. And these are just the various types of pelvic resection you sometimes have to do. Type 1 is just taking out the ileum. Type 2 is taking out the acetabulum. Type 3 is taking out the pubis or ischium. Obviously, this is the one that's a challenge to reconstruct. This was the guy with the type 1, big tumor. We brought all the abductor muscles down, and that's a tumor here that we're going to do an osteotomy just above the hip joint. The only way this patient can be treated is surgery, so we've got to get the margin. So this margin is absolutely imperative that it doesn't go through tumor. Luckily we did. We kept a bit of the hip joint. We were able to span the gap between the sacrum and the hip joint with a free fibrillar graft, which the plastic surgeons raised for us. They plumbed that in. We put that in to give the guy his pelvic ring back. And you can see after taking all that out, that fibrillar graft nicely hypertrophied up over the next year and gave him intact pelvic ring. He was a bit weak with his abductors, but he's tumor-free and didn't get any recurrence. So I'm just going to sort of finish off, if I can, just talking about Ewing's. So Ewing's is the final one. It's that miscellaneous one. It's a small round cell tumor of unknown origin. It's a little bit distinguished that it doesn't quite fit into anyone's classification, but it often presents systemically. It's got a diaphyseal location often, and it's managed with, like osteosarcoma, with chemotherapy. If you do have expendable bones, they can be excised. If it's like a pelvic bone, you sometimes just treat with chemotherapy and radiotherapy. The treatment survival with chemotherapy is similar to osteosarcoma, about 60 to 70%. If you don't give chemotherapy, the outcome is very poor. So this is a poor girl who had this lytic lesion in the femur that looks, maybe could be fibrous dysplasia, could be infection, looks a bit irregular for a cyst, but if you get the MRI scan, you can see there's tumor permeating all the way down the femur. She had systemic symptoms, if I remember. This was Ewing's. She ended up with a total femoral replacement. Because these tumors often occur in the young, the children, you maybe have to think about, can this tumor grow to allow the leg to maintain the same side as the other leg? And so we often use things called extendable endoprosthesis. This is where the implant can actually grow as a child grows. In the old days, you used to just have to come into theatre and put a screwdriver in to yank out the implant. There was a high infection rate with that. So now in tumor surgery, we now use non-invasive growing implants. This is a magnet that the patient goes in every month. And every month they can be lengthened just a few millimeters by going into this electromagnetic field, which means you don't have to come into theatre, you don't have any risk of infection. And because Ewing's is the predominant pediatric condition we treat, we're often treating them with non-invasive growing implants. So I'm conscious I've just slightly gone over my time. I'm happy to stay on and do the MCQs. So this is where I'm going to stop. I've tried to give you a flavour of the classification to try and give a framework on which you can get a bit more detail into. Bone tumours are common, but there's a spectrum. And just using that description of the X-ray can often give you that stepwise assessment. Think about age, site, and matrix. What's the tumour doing to bone, or what's the bone doing to the tumour? And always consult your local tumour centre and always be ready to talk about that in the exam, I think. So in general, sarcoma is a rare, it's early detection referral. Treatment requires an extensive MDT, lots of different subtypes, lots of site-specific surgery required. Oncological and reconstruction are the twin surgical aims, and your adjuvant treatment is dependent on the type and grade of the tumour. So I just ask you, even in your, not just your exam, in your clinical practice, be alert, always assess your patients. No shortcuts here in sarcoma. work them up like as Tom will describe tomorrow. And when you do see these patients, always have the right tools for the job. And we're always here for advice. Thank you very much.
Thank you very much, Mr. Whitwell. That's an excellent talk and quite an important topic for the FRCS. There's always going to be one lesion on the FRCS exam on the vivisection. We'll move straight on to the MCQs and then from there we'll answer any questions after that. If Hannah, you could kindly share the poll. Thank you very much. Okay, so the poll has started, guys. If you don't mind to answer, it's completely anonymous. We won't know who's answered what, but it gives us an idea of how you guys are doing and what areas of knowledge we're imparting on you and if it's working or not. Mr. Whitwell also. Okay, Mr. Whitwell, can you see the results of the poll?
Yeah, thank you very much, everyone. I think, just quickly looking, it looks like most people were listening, which is good. And probably most people knew these because I try to highlight what I know the examiners like. And I think the first one is, which of the following disorders most commonly place a patient at risk for malignancy? I largely talked about all these. I think I didn't talk about neurofibromatosis. And that really is quite low. That doesn't really, that does have some risk, but very low. And I did emphasize quite strongly the 100% from Mafucci. That's multiple enchondromatosis with hemangiomas. Very rare, but that's rare in clinical practice, a bit more common in the exam. McEwen Albright, that's got a small risk. We talked about that. Ollie is 25%, Mafucci up to 100%. HME, yeah, the exam, as I said, the books change about 0.2% for every osteochondroma. So looking at question number 2, what current chemotherapy regimens? Again, I try to sort of give you a bit of a structure. The 3 major malignant bone tumours, Ewing's, osteosarcoma, they're treated with neoadjuvant chemotherapy. You then do the surgery, you look at the histological kill rate, and then you put them back on chemotherapy for another 6 to 10 cycles after that. Chondrosarcoma, only surgery. Really no sensitivity to radiation or chemotherapy. So yeah, it quite clearly that I think you got that right, that it's chondrosarcoma that so I'm actually looking at question 3, so do apologize. I'm talking about chemotherapy shown to improve survival for all of the following malignancies except question number 3, it's chondrosarcoma, as I think I sort of emphasized. Osteosarcoma, Ewing's, lymphoma, rhabdo. I didn't mention those last 2, but chemotherapy is vital. And then just going back to question number 2, because I'm sorry, I haven't got all the screen. I think that's the one where we talked about with current chemotherapy regimens, what are the typical 5-year survival rate? I think if you didn't do chemotherapy, it's 20%. I think you do well if you get up to 70% with your chemotherapy and osteosarcoma. And that's for patients with non-metastatic disease. It obviously goes down significantly if you do have metastatic disease. So most people got that answer right as well. So thanks very much.
Thank you very much, Mr. Well, we have had 220 participants on our session today. And quite a few questions. Excellent talk, and obviously by the questions it's been coming up, it's a topic which is burning hot in the minds of the guys who are preparing for the exam. Nikki, do you want to go ahead?
Sure. So the first question's from Mohammed El Gawadi. It's a bit of a staged question. What if we know before nailing the femur that it was a pathological fracture as a result of a renal deposit? Would that change the decision? And then what after, if we nail it, if it then went on to a non-union, is it indicated to radically excise and replace?
Yeah, I think in an hour to cover metastatic disease in all its depth as well as sarcoma is a tall order, but it needs to be talked about because it does overlap and it is so important. And I think it's changing. It really is. With these new biological therapies in the elderly population, we are facing a big onslaught of metastatic disease. Kidney cancer does not respond very well to radiation. It's got a number of new biological therapies, and actually there is a feeling that you can maybe cure solitary renal cancer to bone. So if we had known that was a pathological fracture secondary to renal cancer, and it was his only deposit in the skeleton, absolutely, he would have had a wide resection, but in that case, it probably would have been a proximal femoral replacement. Why it had to become a total femur was that the nail had pushed all the tumour down into the distal femur, it was all infected, and so that's why we had to be aggressive with a distal femur. So that's my, so I think that we should have not nailed it. It should have been biopsied. It should have been kept in traction. There should have been an MRI scan, a bone scan, a CT chest, abdo, pelvis, and then it would have been clear what the problem was, and we would have recommended a proximal femur and then a secondary nephrectomy once a few weeks after the proximal femoral replacement.
Okay, thank you. The next question is from Maksud Khan. If there's a past history of cancer but no mets, and the cancer is known to be in remission, but the patient presents with a long bone fracture which looks suspicious, should we do local and systemic staging first before attempting to fix?
Absolutely. Well picked up. I think you've got it, because yeah, you're in a busy trauma meeting, and maybe some corners are being cut. But when you're coming to the exam, you're not in a busy trauma meeting. You're trying to do best practice to show you're a safe and considered consultant. So if there's any idea that this maybe could be a primary malignant bone tumour, you have to do all the appropriate staging, keep the patient in traction if necessary, MRI scan, workup for metastatic disease. I would only go straight to theatre if the patient had known metastatic skeletal disease. So if you've got someone who's got a good history or has got an MRI scan with multiple metastatic disease, then you probably could go straight to theatre. But if you don't have that, it's a primary malignant bone tumour until proven otherwise, and it's beholden on you to keep the patient in bed or whatever and do the investigations. And you can get the investigation done reasonably quickly on the whole. And and definitely for the exam, if there's any question, you do that. So it's important. If there is known skeletal metastasis from a cancer, then you can go straight to theatre. Unless you've got that, which I think is your scenario of a previous cancer, that is, to me, that still could be a primary malignant bone tumour. Does that make sense?
Yep. Oh, that's good. That answered your question. So the next question is from Motaz Al-Masri. How can I differentiate between enchondroma and bone island?
It's the radiological thing. It's your matrix really. I think that once you get an MRI scan, you'll clearly see that the enchondroma's got a cartilage matrix. The bone island won't. It will be, the radiologist can easily tell you the difference. On an X-ray, yeah, it might be a bit harder for you to tell, but an MRI scan will be the key investigation.
Thank you. We've got a question from Ali Abdul Hamid. What are the worrisome signs of enchondromas?
Yeah, that does take quite a lot of explaining. And it's that spectrum, isn't it, between enchondromas and low-grade chondrosarcomas. And it's not an easy one. There's not an exact answer. As I try to explain, you've got to just look at all the evidence and largely maybe talking to your local oncology unit, come down. Where I get worried about enchondromas is they've expanded. So sequential imaging has shown a change. Looking at the matrix, there's a bit more lysis around the cartilage component than normal. There's endosteal scalloping. The patient actually experiences pain in the area. And the bone scan is maybe is very active rather than just being a little bit lukewarm that enchondromas tend to. And you tend to balance all that evidence up to decide whether you should do a curettage. But if you think it's an enchondroma, I would still recommend that you get sequential imaging and you recommend that another scan is done in 6 months' time, just so you can make sure that there's no change.
Thank you. The next question, two people have asked the same question. I've got AJ Chirazia and Mohammed Hamdi Abdel Hamid have both asked, what's the difference between a warm and a hot scan?
I think it'll just how it's reported. I think when you do a PET scan, which is, as Tom will tell to you tomorrow, which is our major investigation now for systemic staging, the PET scan will actually give you an SUV, which is the activity of the tumour, the amount of sort of glucose, radiated glucose that's deposited, and that gives you actual value. I'm afraid it's much more subjective with bone scans, and it largely is dependent on the radiology reporting. There isn't a scale that they can really assess. It's a bit grey rather than black on the scan, etc. But they'll talk about lukewarm, tepid. They will give you an idea whether it's bright or whether it is that. Again, that really doesn't help me that much. It gives a bit of evidence when you're looking at Enchondromas and low-grade Chondrosarcomas, but it's not the essential evidence. But PET scans are much better now at giving us an actual figure.
Thank you. We've got Imran Ali, who said, is Morell's score for pathological fractures valid for paediatric cases, or do we have another similar scoring system to guide your treatment decision?
That's an interesting question. I must admit, Morell's, it probably is the one to use for the exam. I think it is still quite valid. Again, Morell's is largely due to metastatic disease, isn't it? And that's very uncommon in paediatrics. So I don't know a paediatric specific one, to be quite honest. I think if you do have a pathological fracture, I think you do need to often get a biopsy, or you need to look at the imaging very closely. But no, there isn't. The answer to your question is there isn't a specific paediatric one that I know of.
I don't think that Morell's is more for metastatic disease, as you said. I don't believe there is anything pediatric at all. So
we do use Morell's to a degree, but it does help. So I think that's still very valid for the exam to have an understanding of Morell's, which again I haven't had time to describe, but it's quite easy to understand if you read the books.
Okay, thank you. We've got Cameron Hafiz, who's asked, are monostotic fibrous dysplasia and non-ossifying fibroma the same?
No, they are different. And non-ossifying fibroma is the very unaggressive tumour. You'd almost call it latent. It doesn't do anything at all. It very rarely causes pain. It's got a big corticated margin around it, so you know that the bone is really warded off, and it's very different from fibrous dysplasia, which is this ground glass appearance and the bone doesn't show any evidence that it's warded off. So they are different pathologies. Fibrous dysplasia and non-fibroma, you'd largely just observe anyway. You wouldn't actually treat.
Okay, thank you. We've got Awaz Sheikh, who's asked, do you use cement on a GCT even in a young patient?
Very good question. I think that's a little controversial area. I like cement. I think it's a very good adjuvant. It heats up, it gives structure, and that heating up really does lyse any remaining tumour cells. So, but still, we get 10 to 20% risk of recurrence. I think a paediatric patient has obviously got some bone growth still to do. That could potentially affect it. So, we do in paediatric cases do largely just put bone graft in.
Thanks. We've got Amra Abula. How do we differentiate telangiectasic osteosarcoma from mimicking benign tumours?
How you do that is to educate all orthopaedic surgeons to be mindful about it and to make sure that they work the patients up properly with the scans and they get a biopsy. And you've got to have it at the front of your cortex and not have it at the back of your cortex and you don't think about it. So the biopsy, unfortunately, is so vital. So we see benign tumours and we think they're benign, but we'll probably get a biopsy just to be sure. And that really can only happen in a tumour unit. So these cases get referred up. So think about that because you can always get caught out. And we see examples of that happening, unfortunately, quite regularly. So it's not just something to scare you. It still happens regularly that telangiectatic osteosarcomas are missed, I'm afraid.
Mr. Whitwell, would any radiological investigations help, including bone scans and or MRI in these situations?
And not particularly. Bone scans could still be quite active. An MRI scan would, that you might see a bit more appearances on an MRI scan than an X-ray, but yeah, the biopsy is the critical thing there.
Okay, I think we've just got two more. So Harry Benjamin Lang has said, for isolated renal cell metastases, how soon after ablation can you operate and what is the window?
Oh, yeah, good question. So renal cell, again, is a subject all on its own because kidney cancers are very vascular. And we've had some frightening days in theatre treating kidney cancers intralesionally. And so, yeah, you tend to, well, you always have to recommend that if you're going to go intralesion into a kidney metastasis, you've got to embolize it first of all. And how we embolize it is with our interventional radiologists. And we tend to try and do that within 3 days of the operation. So yeah, 72 hours is the recommendation. Yeah, I'd probably, if the worst comes to the worst and we've missed that, I would be happy to go up to about a week. But after about a week, new vessels will be growing into that tumor, and so it could be a bit more vascular than you'd like it. Still be prepared when you're treating a renal cell. The classic example is in the pelvis. It's eroded the hip joint. You're trying to put a hip replacement in. The classic thing is that it could still bleed a lot. So even though you've embolized it, it could still be a bit challenging. So I get lots of adrenaline-soaked gauze swabs. And if it does bleed, just pack it with adrenaline-soaked gauze swabs. And that can often staunch the blood flow quite significantly, allowing you to sort of carry on. So that's a little tip if you do ever encounter quite brisk bleeding from some of these metastases. Thank you.
Then we've got Suleiman Yunus. He said, in a case of Ewing sarcoma, or maybe it's in your case of the Ewing sarcoma iliac wing, would you recommend chemotherapy after resection and pasteurization?
Yeah, that's a really nice point. So yeah, what's interesting about treating sarcomas, if you go around the world, there are lots of different ways of doing it. Some people use liquid nitrogen to inside lesions which get curated, etc. And there's some funny sort of treatments out there. What that question's alluding to is the fact that you can take bone, which is affected by a tumour, away at the time of surgery, and you can take it out of the body, and you can go and treat that cancer with some other type of adjuvant. And then in the same operation, you can put it back in, and you just basically plate it back in, and then hopefully with creeping substitution, that the fracture will heal, and you'll have the tumor treated, but the patient's own bone back in. And the pelvis is a classic situation for this. I've had experience of irradiation, so it's called extracorporeal irradiation, where the pelvis is taken out, it's given high dose radiation that otherwise could not be given to the patient with the bone in because it would be too toxic to the surrounding tissues. The tumor's killed, and then you put that bone back in like a bone graft. Another option is pasteurization, which you can put it into liquid nitrogen or things like that. So there are those techniques around. I don't do it in Oxford at the moment because it's quite logistically challenging to do. But it is well recognised as treatments for these conditions. So yeah, he does talk about some ways that some units do treat their Ewing's sarcomas.
Okay, thank you. Mohammed Nail, this is like an exam question. Would you advise to do a biopsy in a DGH or better by a tumour unit?
I
think again, Tom will talk about this tomorrow because there is classic teaching on how you do a biopsy. The key thing about a biopsy is it should be excised at definitive surgery. The biopsy tract should be excised because potentially the needle or the operation has led some tumor seeding along that biopsy tract. So if you're not going to do the definitive surgery, how do you know where the biopsy will be? So we do recommend that any tumour gets biopsied in the tumour unit, and then we can direct our radiologists, or we can do the surgery with the biopsy tract in mind for our definitive surgery. So any tumour specimen we take out often has the biopsy tract attached to it.
Okay, Nikki, I know this is a really hot topic. I really know that a lot of people are got a lot of questions. But to be honest with you, a lot of these questions are now getting to the high level, and I know Mr. Whitwell has gone way over the time that he had allocated to us, and really appreciate it. Thank you so much for the time you've given us, Mr. Whitwell. The rest of those questions are pretty much beyond the scope of the FRCS exam. In fact, some of those questions were already beyond. Thank you very much for answering them.
No problem.
And thank you for your patience. Really amazing talk. Once again, thank you very much. Well over 220 participants watch this, and I'm sure we'll get a lot more hits on the different platforms that we're going to be putting this up on. Once again, guys, tomorrow, Prof. Costa will be here to discuss how to investigate and manage these patients and especially in metastatic disease as well. To everyone, thank you so much for attending. We are, as always, here every Wednesday, except tomorrow, which will be Thursday, and look forward to seeing you again. Thank you.
Thank you very much. Best of luck, everyone.
Thank you.